Okay, so good evening to everyone who has joined. So today we'll have a special session by Jyoti sir on the examination of neck, shoulder, and elbow joint. So without further delay, I'll give it over to Jyoti sir.
Okay. Thank you, Dr. Mahel. First of all, good evening, everyone. I'm Dr. Jyothiswaroop, working as Senior Resident in the Department of Emergency Medicine, AIIMS, Delhi. So today we'll be discussing about examination of neck, shoulder, and elbow. So three things. So today's discussion is all about three things, right? And also I'll give you a pattern and also how to examine. This is mainly about the clinical examination. We are not going to discuss about the pathologies individually, but how to come and derive some conclusion based on our examination. That is what we are going to discuss today. So three things you have to remember always. This is the pattern which I'm going to use and framework that will be easy for you guys to remember as well. So this is all about examination, right? So examination is what? Examination is somebody's, I think, writing on this one. So, okay. Mehul, look after that. Okay. So, like examination consists of what? Inspection, palpation, percussion, auscultation, right? So we use five senses. So what are our five senses? Like sight, touch, hearing, taste, smell. So out of this, we are not going to use smell and taste sensation anyway. So in this, and also auscultation only rarely, for bruit in neck examination and also some peripheral regions we are going to use. So other than that, mostly our examination will be of three things only: inspection, palpation. Percussion is the, percussion, this reflexes. So that is what the percussion is all about. And so we are only going to use three senses. And hearing is, we are going to hear history, like that is what hearing is all about. So like this is mainly about the musculoskeletal. So this is also three things we have to remember in examination part. So three things, again, history, examination, and some tests, special tests, and also some nervous examination, like neurological examination. Okay. Then after that, like in examination, again, inspection, palpation, and range of motion. Okay. So here we will be going to like first look, feel, move, and test. Like we'll be looking or inspecting the patient's condition and also the posture, everything, and also we'll palpate. Then we will move. The patient will move. The range of motion will be seen. Then after that, we will do some particular range of motions and also special tests. So here we are discussing about what? Mainly musculoskeletal. So we have bones. When two bones are joined, that is called as joint, right? So the bones are like cemented together with what? Ligaments. And to move this structure, this hard structure, we have some soft tissue, that is muscle. So, and to support this, we have neurological, like neurovascular system, and we should always examine that one as well. Okay, so three things we have to always remember again. So we will jump into our first neck examination. So neck, as you can see, it is, a big, like almost like a confluence structure, and it connects head to the torso. So you can see here, I always look into a neck as a, important structure, because it is a pathway for many things actually, as you can see here. So if you see, anteriorly we have airways, right? The way for air. Then after that we have, esophagus. That is like almost like I consider that as a roadways. So esophagus, and we have vessels like carotid, and also these are the main major vessels for our brain. So carotid and other things. So head, these are the things, and jugular veins. So that I consider that as navy. And posterior to that we have, vertebrae, which are arranged like, some bogie of train. So, and also the train will have, you can see it, like derives its, electrical supply from this one. So that is the spinal cord. So I consider that as a most important structure. And also, as you all know, airway with C-spine immobilization is like, with airway on par with airway, C-spine immobilization is given. So the cervical motion restriction is important. So neck examination is that important. So when we go into this, so we are not going to discuss all the gastrointestinal or vascular system. Only we'll be discussing about the musculoskeletal only. So we have many muscles like longus, capitis, coli, rectus, capitis, lateralis anterior. Then also on posterior aspect, we have like upper trapezius, levator scapulae. So there are many muscles. And also spine, cervical spine can be usually divided into, like we have C1 to C7, right? 7 vertebrae. So C1 is atlas, C2 is axis. Again, from C3 to C7, we call it as subaxial. Again, there is a pattern of 3 here as well. So atlas axis and also subaxial spine. So, and also various muscles as well. Okay, suboccipital muscles based on that, and also posterior muscles of neck and other group of muscles. Okay. So again, now we will be going into the like the examination part as well. So like C1 to C7. So it is highly mobile and there is multi-directional head movement is there. And it accounts to like 50, like the mobilities accounts between like the atlas and axis, like they will take care of some movement, and also the subaxial spine also take care of the other movements as well. So, and we should look at the alignment as well. So normally there will be lordosis. If it is lost, there could be some pathologies. Normally, common pathology is the cervical spondylosis, where lordosis is lost, and there will be muscle stiffness in these patients. So, and also nerve roots and spinal cord should be examined. So, history part, always patient will come with what? Spine examination, usually there is any trauma history. Obviously, there will be injury. If a patient will complain of pain, so for any pain, usually we have site, onset, like Socrates type of thing. So onset, radiation, alleviating factors, any changes. So this is a bridge, right? So, and also it connects, it's like a highway, and it is very important. And if there is any cervical spine injury, what will happen is quadriparous quadriplegia will be seen, and also respiratory compromise can be seen. So that's why we should also examine this nervous exam, like neurological examination should be done in these patients. So like pain is one thing, weakness, then other exam like reflexes and other things should be seen. So history components, key components, like based on the like based on what patient complains, if he is conscious, then we should derive it. Otherwise, if the patient is unconscious and trauma patient, we'll directly go with C-spine immobilization in these patients. So common conditions in a conscious patient, usually disc herniation, degenerative spondylosis, radiculopathy, and other causes. So this patients can also have additionally gait instability and history of previous procedures that can again increase the susceptibility for further future injuries as well. And symptom duration also will have an impact. So acute versus chronic as well, and other trauma histories. So in history taking, we will look into these pain, stiffness, weakness, and other things. Then characteristic of pain, then trauma, mechanism of injury, and in any systemic complaints, like in terms of fever, history, like weight loss. These are some red flags actually. So any neurological symptoms, these are all red flags for us. So weakness, loss of bladder and bowel control. So these are the so we should consider that, and also evaluate. This is a high priority patient, so obviously we have to take care of those patients. Okay, and examine properly. So again, so this is the history part. Now again, examination, we are going to use all these things. So again, we will be seeing general examination will start with inspection, right? So posture is the most important thing, then spinal curvature. Lordosis will be there. If there is loss of lordosis, we should suspect some pathology. So we should look into the asymmetry, then after that, posture, alignment, then visible scars, discoloration or muscle wasting, anteriorly, posteriorly, laterally. So all aspects we have to look into. If the patient is conscious, obviously we'll do that. In a trauma patient, in unconscious, or else in patient with accident, so usually we directly place cervical spine collar usually. So before that, we should have a only anterior at least. So we should examine those things. Then palpation, position is important again. So there are two things, like we have to palpate bony structure, soft tissue. Bony structures again, from we can't, there is no spine for C1, right? So usually C2 to C7 usually. So we will palpate that, and C7 is the most prominent, has a spinous process. So we will palpate that. Along with that, soft tissue, paraspinal muscles will be examined. Like we should palpate for tenderness, trigger points, and also in these patients, like we will also palpate, normal any other tenderness anteriorly as well. And in patients with trauma, usually we should also like look for any changes, like any crepitus, laryngeal crepitus, like tracheal lesion. So airway injuries also we should like examine in neck examination as well. Okay, and then in palpation, usually like patient, if he's conscious, then obviously he'll complain of pain regarding that. Otherwise, then we'll move on to the range of motion assessment. So normal neck flexion, extension, these are the various movements. So 90 is the like flexion and axial rotation. Then 70 degrees of neck extension is normal. Then lateral bending is 45 degrees. So we'll look this video. So you can see in this. So here, this is flexion. Then this is extension. Then there is lateral bending where our the ear should touch the shoulder. Like that is what so this is lateral bending or side bend. So then after that, cervical rotation. So this is the cervical rotation. Okay, so I'll again show you. So the neck flexion should be 90 degrees. Then neck axial rotation should also be 90 degrees, normal range. And also like neck extension is around 70 degrees. And also lateral bending is 45 degrees. Coming to the sensory examination. So sensory, this one, neurological examination, sensory, motor, then reflexes. Three things you should examine. Sensory examination is like sensation, like we should like dermatomal examination. So like in this video, I'll see, I will show you. So sensation, sensory examination. So we'll usually ask the patient to place and explain the patient. Either you can, if you don't have any this one, so usually you can just ask for the patient. Otherwise, if you have any soft crisp of like cotton, that would be better to look for any light touch, like crude touch, this one, and also sharp pain as well, like in terms of needling, this one. So sharp pain and also vibration. So these are the things we look for usually. So you can see like C4, like C5, C6, C7, C8, T1. And also the little finger is the C8. Medial portion, again, when we go more this one in the flexor component, so the forearm and arm, there is T1. Okay, so we should check for the baseline normal sensation, light touch, sharp sensation, and we should document whether it is normal, impaired, or absent. Okay, so this is the dermatomal distribution of the upper arm. And coming to the myotomes, so, C5, C6, C7, C8. So we can ask the patient to shrug the shoulder. This is C4. Then after that, abduction, shoulder abduction will be, that is deltoid C5. Then flexion, that is biceps. So that is C6. Then extension, triceps of the forearm, like this is C7. Then the thumb, this one is C8. Okay. Then after that, finger abduction, this one, palmar, like adduction and abduction of this one. So T1. So these are the like myotomal distribution of the this one. So any neck injury usually causes abnormality in all these things. And also by doing this, we are also examining the all joints like shoulder and also elbow and wrist. Everything is done in this examination as well. So whenever we are doing this examination, normally myotomal, we will always see tone and power, right? So tone, like whether there is a hypotonia or like this one, we have to comment on that. And whether there is spasticity or this one, so we can comment on that. And also coming to the power, like 0, 3 is against gravity, 5 is normal strength. So we should comment on the power as well for each joint. Okay. And coming to the reflexes, again, 0 is absent, 2 plus is normal, 4 plus is hyperactive and with clonus. So like based on this, we have to examine. Then after this comes the special test. Special test, like if there is any pain, so we should provoke. There are something called as provocative tests. Then if there is any dysfunction, we should go for functional tests. If there is any instability, like in terms of ligaments, this one, we should do some stress test. And if there is any numbness, we should do some neurological tests for looking for any radicular signs and this one. Okay. So a special test in cervical spine examination will be Sperling's test, which reproduces, we are actually provoking this one. So like radicular symptoms in cervical radiculopathy. And also there is something called as distraction test, which will relieve actually the symptoms. And there is a Lermit sign and also Valsalva maneuver. This is actually for the any interdural pathologies. This one. Okay. So Sperling test, the patient will be positioned towards the affected side, then neck will be extended. And also if the pain, there is any pain, numbness or tingling sensation down the ipsilateral arm, then it is considered as a positive. And to increase this one sensitivity, usually we apply some pressure as well. So in this video, you can see. So we'll ask the patient to like there is some cervical rotation, then after that extension and also, okay. So there is a combination of these three things. See, there is extension, then also rotation. Okay. Then after that patient will be, so this decreases, this is on the left side, right? So And also now I'm applying the pressure actually. So pressure, the axial compression. So this will, if there is any positive like pain, this one, or numbness over the ipsilateral, so we will do that. And on the same, similarly on the other side we have to do. So this will decrease the space between the vertebrae, so that will compress. So this can reproduce this one. So and also normal palpation, everything should be done along with that. Okay. So and the next one will be Lermite sign. Lermite sign is like when patient flexes. This is a passive flexion. Usually, if the patient has a pain, obviously he won't do it. So obviously we should do a passive flexion. So passive neck flexion will reproduce electric shock-like symptoms that can radiate to into your arms and legs, and this will indicate myelopathy, multiple sclerosis, and other demyelinating. So this is also one of the neck examination findings. So this will be like a lightning. The other reflex will be the Hoffman's reflex. Like usually we'll do this. So we will hold the middle phalanx and also we will tap on the distal phalanx. So if there is any flexion of the thumb and the other fingers, so usually that is considered positive. So this indicates cervical myelopathy. And the distraction test which I was talking about, like telling you about, was this one. So we will hold it, we will stabilize, and also pull. If the patient is in supine position, we will give an axial traction that will push, like pull the like neck and head upwards. So that will decrease the pain actually. So there is a positive result will be diminution of patient's radicular symptoms. So this is the manual neck distraction test. And the other test will be the Valsalva, which like if the patient has pain, then it indicates anything like or cough. This will increase the pressure, right? So it gets transmitted into the head. So obviously intradural or spinal pathology should be suspected. And the other test is the swallowing test, like the patient, if the patient has any dysphagia or pain during, you suspect some other pathologies, some abscess, something. Okay. Then supplemental examination is of this other underlying structures of the neck. So carotid, like the vascularity, and this one Bruy for Bruy. In a patient with diabetes, hypertension with hyperlipidemia, usually we should do before doing any like manipulation of carotid. So usually that carotid auscultation is done for Bruy, and lymphatic systems and any lymph node enlargement, and cranial nerve examination and oropharyngeal examination should be done. Then if we find any abnormality, obviously, and if we are not sure, obviously we'll go ahead with further investigations, because our senses are unable to elicit or come to a diagnosis of this like any pathology. So obviously we will further investigate the patient. So X-rays, MRI, and CT. MRI is for soft tissues, and CT, and this one is bony imaging, and this one. And X-rays initial, and it is not that sensitive usually, because only in certain this one it can show us, like in only spinous process fracture and also some hangman's fracture, we should be more careful for X-ray. So CT is the better option, and MRI is for soft tissues. And also, you should all remember whenever you're prescribing any the CT, so and X-ray. So one X-ray, this is from up to date. So the source is reliable. So this is spine radiography. You can see 1.4 millisieverts. So almost like half year of radiation. And CT spine, when you give, it is almost like 3 years of radiation. And fluoroscopic, any interventional angiogram of this one will 1.5 year. And CT angiogram of head and neck is 4.5 years, almost 5 years. So this is how much radiation with like it, patient gets when we do CT and this one. So we should remember that. So to summarize this, so like based on the lesions, various areas can be affected. C2, C3, C4, and the various areas can be affected on this. Okay. And thoracic lumbar. And there is something which you have to remember in neck examination. We divide a neck into 3 zones: zone 1, zone 2, zone 3. Zone 1 is clavicle, or this one to this cricoid. Zone 2 is the cricoid to the mandible, and zone 3 is superior angle of like beyond that. Okay. So like based on this, so this is zone 1, zone 2, zone 3. So, and we should also suspect some pathologies if we have any tenderness or any abnormal findings. So based on this, and certain patients will have, if there is any sudden movement, even in a like in a barber, like in a hair salon, usually they will do this sort of motion, right? So normally they will do massage, and after that they will make a sudden head movements that can have a suddenly, there can be tear of brachial plexus, and also the cervical spine injuries as well. So many such incidents were reported as well. So in these patients, so we should also suspect there is something called a cervical burner, like, or a stinging type of sensation. Patient will feel like burning sensation, and because of some neurological injuries as well. So sudden movements can also produce. Okay, so and so in zone 1 we can see major vessels and other things and lung abscesses. So these injuries should be suspected. In zone 3 again vessels and also airway and also gastrointestinal tract like this one, esophagus and other things. We should suspect, and neurological injuries, nerves like vagus and recurrent laryngeal nerve should be suspected. In all these three, spinal cord and other things. Okay, zone 1, zone 2, zone 3. So these are the things you should remember. And also lymph node examination. There are 7 levels of lymph nodes. So usually based on that, we should also suspect some other non-trauma or other, like in a patient with the cough, cold and this one. So usually we'll find some lymph node enlargement, tenderness. So, and also other, quinces and other things as well. So that is all neck examination, and we are not going to into the lymph node examination. So that is the neck exam. So to summarize neck examination, so a thorough examination requires what? Inspection, palpation, range of motion, and also assessment and special tests. So in inspection, we'll look at the symmetry, swelling, and deformity, and we shall observe for posture and also alignment of the head and neck, and we'll check for visible scars and discoloration and muscle wasting. In palpation, we are palpating hard substance, then soft substance. Hard is the bony prominences and other things, and soft is the muscles and other things, and any tenderness, trigger points, and lymph nodes and other things we'll palpate. And range of motion is this one. So because we are looking into the musculoskeletal, so range of motion, flexion, extension, lateral flexion, then rotation, and we will assess for pain and restriction movement. And neurological examination, we will assess for strength, reflexes, and also sensation. And we will also perform Sperling test for patients with the cervical radiculopathy. Okay, so that is all about the neck examination. If you have any doubts, we'll discuss later on. Okay, in the last, after I will complete the elbow as well. So we'll start with the shoulder now. Shoulder, is a peculiar name. I would like to call it as with C actually, shoulder, SCH. This will also give us some idea of underlying bones as well. S for scapula, C for clavicle, and H for humerus. So, and also I search for the etymology of this one. So even if you see this, the shoulder is in Dutch is called as shoulder. Let's see actually shoulder. So it is actually I found it correct in this one in terms of like we have three things. So normally when we consider shoulder, what we do is only we think about one joint. That is the glean. You can see my cursor, right? Mehul?
Yes, sir, it's visible.
Okay, you can see my cap. Okay. So you can see this is the only glenohumeral, but we have other joints as well. There is this sternoclavicular, then there is a acromioclavicular, and there is a gleno. So there are three joints, but we only focus on this glenohumeral. So actually these three should be considered as the complete this one examination of, if we have to completely comprehensively examine shoulder, we should examine these three joints as well, not just the glenohumeral. So we will go into that. And whenever patient present with this one, so they will present with what? Usually pain and also weakness. And also they'll have some instability type of thing. They'll find it like their, weakness and other things. They can't do any overhead activities, and these sort of things usually will come with that complaint. So any tears, arthritis, or any radiculopathy. So these are the frozen shoulder. So these are the various pathologies patient can come with. So if you see this picture, so here you have skeleton, right? So skeleton with no arms and no limbs, like lower limbs as well and upper limb. So here you can see this axial skeleton. This is all is required, and usually the clavicle and scapula. These are called as shoulder girdle. So these provide, actually, you can see scapula is not attached to the posteriorly it is not attached anywhere actually. Only the clavicle is attached here. Wait 1 minute, sorry. Yeah. Only the clavicle is attached here at sternum with sternoclavicular joint. The scapula is not attached anywhere posteriorly. So here the clavicle is providing support. The scapula is also providing support for the entire arm here. So the main purpose of this shoulder girdle is to provide and also transmit the weight of the entire thing. So these three things, like there is sternoclavicular, acromioclavicular that stabilizes clavicle and scapula. Then we have glenohumeral, that is the for the arm. Okay, so this is about the bones. So here again we have coracoid, this one as well, and there are some ligaments as well. Okay, so this is the there are three bones here. Okay, it's clavicle, scapula, and humerus, and the joints are actually three joints. But the first joint which we have to look into this sternoclavicular, then acromioclavicular, then glenohumeral, and the fourth joint is the scapular. It is not a physical joint. It is not a synovial joint. Like scapular articulation with the posterior thorax is not a like a physical joint as such. But the motion with which we do, like when we do abduction, usually the scapular manipulation will be done. Scapulohumeral rhythm, that is called a scapulohumeral rhythm. So there will be that. So usually that it is not a completely a joint, but it acts like a joint physiologically. So these are the four joints which we have. Okay. So the girdle consists of scapula and clavicle. Then after that we have humerus. Okay. Then so these are the four joints you have to remember always when you this only completes the shoulder. Then only it is considered as shoulder, right? So we should always remember not just the this one glenohumeral, so but the other thing. That's why I'm emphasizing this. Okay. So whenever after this bones should be should be tied together, right? So this will be done by whom? Usually, obviously, by what? Ligaments. So ligaments will be tying the bones together, right? So we have many ligaments, and to move, and you can see this. So there are coracoclavicular. These are the coracoclavicular. Okay, coracoclavicular. Then there is coracoacromial ligament. Coracoacromial ligament. Okay, then acromioclavicular. Okay, these are the various ligaments, and along with that, there are some bursa to have some, the bursa always provides some frictionless, like to improve the movement mobility, and with less friction, so obviously there will be some bursa as well. So these are the spaces. Okay, and also like I've also come across one patient recently, like so this patient was having this like you can see humerus is normal. Humerus is attached to the almost like glenoid labrum, and it is normal, and its articulation is also normal, but the patient had some prominence over this one. So this pathology is what do you consider? So this is there is you can see the shoulder has gone down, but the clavicle, this part has come up. So there is loss of acromioclavicular. Joint is disrupted here. So the joint complete disruption. Because of this, you can see a prominent structure over here. So this will lead to obviously improper motion and this one as well. Okay. So a patient can't move his shoulder. It seems like almost like patient is having some, some shoulder dislocation or some fracture, obviously. So on a clinical examination. So we should remember that, and you should not forget the acromioclavicular joint examination. So this happens usually because of sudden fall over this one. So when patient directly falls, usually there can be direct disruption of the and you can see here in this picture, this disruption is there, but it is attached with the coracoid. The clavicle is attached with coracoid. This will have a minimal impact, but whereas you can see this has there is complete loss of coracoclavicular as well. Okay, so this is also lost. So this is a more severe injury actually. So this will lead to this sort of X-ray. Okay. And you should remember the glenohumeral contribution of this one. Okay, so there is a scapulohumeral rhythm, which leads to motion of scapula and humerus to achieve a shoulder movement. Okay, and it is almost like in overall movement, usually to achieve 180 degrees, there is 2:1 between glenohumeral joint and scapular rotation. Okay, during the first 30 degrees of when we do this, right? So when we do this motion, during the first 30 degrees, abduction flexion occurs without any scapular motion, and beyond that there is scapular motion happening. Okay, so with every like 2 degrees of glenohumeral abduction, scapula rotates upwards 1 degree, so 2:1. Okay, and when that is that. Okay, and there are multiple bursa as well. Okay, now these are all about, we have discussed about what? Bones, joints, then after that ligaments to some extent, then after that comes our muscles. Okay, muscles, again, there is three, like we divide into three, this one. So the pattern is three. So we divide into like extrinsic, intrinsic, and pectoral. Extrinsic is like the posterior axial skeleton to the shoulder, like from vertebrae or spine to the shoulder muscles. Then after that, intrinsic scapula, intrinsic is within the shoulder girdle and humerus, between these three actually. Then pectoral region muscles, anterior skeletal to the shoulder complex. So these are the three muscle complexes which we have to examine when we do this. So the extrinsic muscles are trapezius, levator scapulae, rhomboid major, latissimus dorsi. And the muscles of pectoral are pectoral is major, minor, serratus anterior, and also subclavius. Then intrinsic muscles are deltoid, teres major, and rotator cuff muscles. So these are all our intrinsic muscles which attach like from scapula to humerus or clavicle to humerus. So among these three, those are the intrinsic muscles. Again, now coming to the examination. So I've discussed we have discussed regarding these three, the important points which we have to examine, the anatomy which we have to examine now. Okay. So now we'll come to the examination part now. So examination, again, I told you like three, the pattern is three, right? So history, examination, tests. So look, feel, move, and test. So we have bones and joints, ligaments, and muscles. So we are doing what? Inspection, palpation. Percussion is like for reflexes, and this one usually your percussion is not at all in this regard. Usually is not required. So inspection, we will observe for what? Symmetry. We will compare both shoulders. Then deformity, and for any dislocation or fractures, swelling or atrophy, muscle wasting, chronic patients with any frozen shoulder patients on this one. So scars and skin changes for surgeries and redness on this one. And posture, any winged scapula or winged shoulder. So we will look for all these things, scapular winging and visual cues for this one. So we will examine the patient anteriorly and also posteriorly, like in both this one. So we will find some clues regarding the patient's condition of the shoulder. Okay. Then we will come to the palpation now. Again, palpation, we have what? Again, bony landmarks and also the soft tissue. Okay, bony landmarks will be what? Again, we have to start with the center to periphery. Okay, center is what? This sternoclavicular joint. Then we will go on to the clavicle. Then acromioclavicular, coracoid. Then the spine of the scapula. Then this part. Okay. So this is how we go. Then soft tissue, again, rotator cuff muscles, biceps tendon, and we'll look for joint effusion and we'll check for fluid, this one. Okay. So this in this video, you can see the palpation. So we will start with the center point and also I'm examining that. Then after that, we will run over the clavicle always. So we will start from clavicle. So the mnemonic which you have to remember is A, B, C's. Okay. A for AC joint, B for biceps tendon, C for coracoid process, then S for subacromial space. So always start from that. And when you go to the periphery, like almost like the end part of the clavicle, you will find a bump. That is the coracoacromial, this one. Okay. Claviculoacromial joint. Okay. AC joint, acromioclavicular joint. So there you have to palpate for any tenderness. So patient can complain of tenderness over that. Then after that, just above the armpit, usually we will run over this one and we will able to appreciate. You can also virtually examine yourself as well. So you can palpate for the biceps tendon, and also you can just move your arm here like this and also palpate for the tenderness of that biceps tendon. Then after that, like when you palpate that, again you will start from the clavicle, just before ending the before AC joint, you have to just go like below and also palpate for some bony prominence here. So that is our coracoid process, and also apply some pressure. So we should also so whether there is any coracoid tenderness or not. Okay. Then after that, when we when we complete this examination, then we will go again, start from the clavicle again. Then after that, we will go behind to some extent. So here we have the acromioclavicular, right? So again, there is bump, right? We should trace that bump posteriorly. Then we will find the subacromial space. Just below that spine, we will find the subacromial space. So here we have to apply some pressure and look for this one. Okay. And we can just move, do some motion. Okay. So this is the palpation. So A, B, C's. This is the mnemonic which you have to remember. And now coming to that, and then we will do some, again, special tests. Again, the pattern is same. So pain, if there is pain, you have to provoke. If there is dysfunction, you have to do some functional tests. If there is any instability because of what? Joint instability, obviously. So we have to do some stress test. If there is any numbness, you will do some neurological tests and radicular signs. This is all mainly for these neurological tests is for any spinous or brachial plexus injuries. So that is the special test. Now coming to the motion, range of motion. So in this one, you can see like scapular motion should be checked, and also humeral motion. So scapular motion, so towards the spine is the retraction, and away from it is the protraction. When it is above, that is the elevation, then below is the depression, and downward rotation motion. So that combination of that. Then in the humeral part, you can see here, flexion and extension is the just in this plane. Okay. Then after that, adduction, abduction is towards the spine and away from spine, and rotation, lateral and medial rotation. So this is about the like range of motion. Okay. So then you can see this. We will ask the patient to do flexion, extension, abduction, adduction, everything. So yeah, so this is abduction, almost like 180 degrees. He can do that. Then after that, flexion again. Yeah. So then extension. Then he will circumduction. Yeah. This is the circumduction. All motions you can see in this. Okay. So individual can do circumduction of the other this one if there is any proper this one. Okay. So full painless this one. So we will so if you see this, full painless range of motion requires what? Normal glenohumeral joint, intact rotator cuff tendons, and functional rotator cuff. So not just intact, it should be functional as well. So then only painless range of motion can be appreciated in these patients. So joint should be there, then tendons should be there, and muscles. So these three should be functioning normally. Then only painless range of motion can be appreciated in these patients. So the range of motions, like the range is like abduction is almost like 180. Like you can do 180 degrees. Then after the adduction is around, this is the adduction part. So towards the spine, like the humerus, we are bringing towards the spine. So it is around 45 degrees. Flexion is again, you can do this motion. So that is the 180, 160 to 180. Extension is behind. So 45 to 60. Then internal rotation is this motion. Then that is the 60 to 90. And also external rotation is 70 to 90 degrees. So we should also do active and passive on both sides. That should be done. And normal values, usually it can vary, right? So obviously we should compare with the normal contralated side. So active versus passive. And we should also do some key observations. This one, in this one. Okay. So this will differentiate. Okay. I hope everyone recognizes this. So can anyone tell what this is? This test is? Somebody from Mehul, you can choose them voluntarily. Did Dr. Dilip or Vidya, Chandrasekhar, anyone? I'll play it again. Are you there? Sujo? Mehul?
I think we'll allow Vishnu Kutan to answer now.
Okay. Vishnu?
I don't know, sir. I don't know.
What?
I don't know.
Okay. So in this one, there is something called as Apley scratch test. Okay. Apley scratch test. Okay. So I request every one of you to just do this one. Like this can just scratch test is what? Like if you have any scratch, usually you will do this one maneuver. So reaching to the opposite scapula like this, and this is like you can see it tests subduction and external rotation. This motion. Okay. So that is there. Then after that, you will reach out to the other side. Okay. In this one, like in a scarf test. Okay. Then after that, you will do the posteriorly like this one. Okay. You will test for the adduction and internal rotation. Okay. So this scratch test is almost like it will give you a complete examination, like overview of the muscles, tendons, everything of the like almost all motions are tested in this test. So obviously, external rotation, internal rotation, adduction, abduction, everything is tested. Okay. So these motions should be done. Okay. Posteriorly is one thing, then anteriorly this part. Okay. So this is called as Apley's scratch test. So here he's doing Apley's scratch test only. So his rotator cuffs are to some extent normal. Only we can see only one part of it. Okay. So we will look into the different examination parts. Okay. So this test is empty can test. Okay, we are checking for the supraspinatus muscle. Okay, we should ask the patient to resist the downward motion. Then after that, external rotation. For external rotation, we will do some motion. Okay. Then also we will also do for internal rotation. Similarly, on the inner side, we do the internal rotation as well. Then this is the belly press test. So usually we'll ask the patient, this is the internal rotation part only. So we'll ask the patient to push it. So we will test for the, this one, okay? Internal rotation, we are applying some resistance, okay? So that is the belly press test. We will apply some pressure here, okay? Then after that, we will ask the patient to do some, this is called as lift off test, and also we will ask the patient to do the internal rotation, this one, okay? This measures, this tests the subscapularis muscle, okay? So this is the lift off test. We'll apply some resistance. So this is the lift off test. Then after, with the other hand also we will do contralaterally to check for the symmetry. Then this is the Hawkins test. We are actually reducing the subacromial space, this one. So if there is any pain, obviously patient will complain of, he won't be able to complete this test as well. So obviously, so this is one thing. Flexion, then also we will doing some internal rotation here, okay? And we are doing the crossing over, almost like adduction as well. So we are reducing the pain. And there is something called as knee impingement test. We are passively raising the arm, and also this decreases the space, subacromial space. If there is any pain, obviously, like because of supraspinatus, like this one, subacromial tendinitis, so there will be that. And this is called a scarf test, and this is this is for the acromioclavicular joint. So when there is any pain and also restriction, though obviously patient will have this pain. Okay, scarf test. And there is something called as O'Brien's, and there is a adduction part as well. So that is another test. And this is the speed test, where we are looking after the biceps tendon. We are checking the biceps tendon bilaterally. So we are applying some pressure and asking for this one, okay? Pain and also weakness and this one. Then there is Jurgensen's test. This is like we are biceps is supinated, right? So usually if there is any, if the patient is able to resist the supination part, that is normal only, okay? Yeah. So we are checking for that bilaterally. Okay, and this is the horn blowers, like almost like we are checking for the external rotation here. These are all the tests we do for, like, we are already completed all the rotator cuff muscles in this video. So almost all tests are covered. So we now, like after joints and this one, so like we are checking for the functional. These are the function tests which we do. And knees impingement test, these are the impingement tests. And biceps is for the, like the speed test, and Ergenson's test are for biceps, this one, okay? And there is something called as drop arm test for rotator cuff tear. If there is any tear, what will happen is we will make the patient, like we will make the patient's arm like in abducted position. Then after that, we will ask the patient to slowly bring the arm downwards, like adduction. So if the patient is unable to resist that part and unable to do slowly, so that means if there is any sudden fall, that means that is called, there is positive sign, and that suggests some rotator cuff tear, okay, a supraspinatus dysfunction. And there is something called a sulcus sign. So we will like patient, the arm will be adducted. You can see in this one, adducted position, adducted position. Then after that, we will apply some pressure, downward pressure. If there is any appearance of sulcus sign, you can see in this picture. I hope it is clear. So this is the sulcus sign, okay? So this is like in this, so if there is a sulcus sign, it means inferior instability. Okay, and this is the Hawkins test, and this one, okay. And there is something called as apprehensions test. Normally, we all know, like in terms of anterior dislocation of shoulder, this one will be outstretched hand, abducted, and also external rotator arm. So we will do some similar maneuver here in apprehension test, and we also will apply some pressure actually. So this will, if the patient feels that the shoulder is unstable, so obviously this is called, that is why it's called an apprehension test. It means that the joint is not stable enough. So then after that, we will also do some relocation test in this one. So this also suggests some instability. Patient will express relief in this because we have applied, we have posteriorly pushed it. Now it is anteriorly, like from anteriorly we will push it. So it is almost like a relocation, like reduction maneuvers actually. Okay, to summarize this one, so you can see this various this one. So palpating cuff defects and also crepitus and also motions of various other like muscles. This should be done in shoulder. Okay, and these are the sensitivity and specificities of various tests actually. So acromioclavicular joint tenderness, almost like 96%. And also tenderness with compression of acromioclavicular joint is 79%. And cross-body adduction test, like scarf test and also O'Brien's test. So this also 77%. And the other tests, so speed test, Yergeson's test, and so rotator cuff tendinitis, you can see in this table. And we like individual findings. This is from one article, so I'll share the reference as well. So examination, to conclude, like examination of the shoulder is inspection, palpation, range of motion, again specific maneuvers. So we are looking at what? Asymmetry, swelling, deformities. Then also look for any muscle atrophy, especially in deltoid and supraspinatus areas. And also we are checking for skin changes, any scars in previous surgeries. And we are palpating, almost start from the sternum and the sternoclavicular joint. Then from the you run over the clavicle. Then after reach the acromioclavicular joint, apply some pressure over there. Then after that, do this. So tenderness, swelling, crepitus, this should be elicited. Then range of motion test, active range of motion and passive as well. You should do both. So flexion, extension, abduction, adduction, and internal and external rotation, and active and passive. So this will differentiate from conditions. And then special tests like impingement test, Neil's Hawkins Kennedy test, and rotator cuff, like we have already demonstrated that. So MT can and external rotation tests and lift off test, and stability test, again anterior stability and sulcus sign and biceps tendon. So this is the virtual exam. If you want, if you want to examine, you can do this with, like, normally everyone of us, like, you can just ask any patient as well on video call. You can just ask the patient to do this examination. Like the other arm will be acting as a testing arm. This one is the probing arm. So like if I want to test my right arm, so I can do, like, if I want to check my external rotation, I can do this maneuver. So like at least, so I will resist the external rotation here. So similarly, we can do all the tests with this. Okay. And the inspection, palpation, and the range of motion test can be done. Okay, with this. Now coming to our last part, elbow. Again, you can see shoulder has three bones, and three joints, but one joint is the scapulo-thoracic one. Here also we have three bones again, humerus, and again radius and ulna. Okay, so humerus and radius and ulna, we have again bones, this one, and also ligaments on the medial and lateral side. Then we have over it muscles to move this. Okay, hard substance. So the hard structure, that is the, like, we have extensor compartment and flexor compartment. Extensor, like on the lateral side, and on the medial side, medial epicondyle, you will have the flexor compartment. So all flexor tendons and also pronator teres, this one, everything like will come on this side. And on the other side, usually we have the extensor tendons. So the test depends on the concept of this one only. So extensor and flexor of wrist and also fingers. So normal pain, the patient comes with what? Usually trauma. There will be some fractures. In children, pediatric age group, obviously after fall, usually you'll find supracondylar fracture, right? So that is one common, this one. And in elderly, usually, like, you won't find elbow, this one, but distal end of radius and this one will be seen. Okay, so then overuse, like golf elbows, and some bursitis as well. Okay, then arthritis, osteoarthritis, rheumatoid arthritis, one thing, and also some nerve compression, cubital tunnel syndrome, and some referred pain. Okay, so again, our pattern to the approach will be same. So history, examination, and tests. Okay, special and neurological examination. Then we will look, that is look, feel, move, and test. Again, we have bones, joints, ligaments, and muscles, and to support these things, neurovascular structures. Okay, so we are going to use this one. So inspection, palpation, percussion, again reflexes. Then there is no auscultation only for Brui. And if patients with, normally elbow usually will have what, like and other things. Usually if the patient has a CKD with this one, so usually we will auscultate for any this one. Okay, fistula and other things. Okay, for that elbow examination, I have included for that. Okay, now the history part, again will assess for the pain, injury, and functional limitation, the impact of the on daily activities. So here in inspection, what we'll look for: skin, asymmetry, swelling, deformities, and scars. Again, we look for the signs of valgus and varus, and there is something called as carrying angle. Carrying angle is See, if you can draw a line from the humerus, then after that a straight line, then after that another straight line from this one. So that is what is carrying angle is. So carrying angle normally is around 5 to 10 in males and 10 to 20 in females. Female has a higher carrying angle. So coming to the palpation now, key areas we will palpate like medial epicondyle, lateral epicondyle, olecranon, and radial head and other things. Then look for in temperature, any bursitis and this one. So and tenderness, specific points. So we'll palpate the structure. So we'll look for the 3-point maintenance. So usually that is isosceles triangle. And also we'll look for tenderness above. So we will palpate above and below as well. Any tenderness. Then after that, when you look into this one, so that is the olecranon process. Now you'll find bilaterally there is some fossa, like there is some groove type of thing. Okay. So if there is any fusion, obviously that will be that won't be visible actually. So any structure that is there, so obviously if you are not finding that groove, obviously there is some pathology. So you have to further evaluate in those patients. And when you palpate that and also do some movement, so you will find the radial head over there. So radial is on the lateral side, right? So obviously you will find that. So when you do the supination pronation movement, so you will find this. And in this, so and also you'll look for any pulse and this one. And okay. Then after that, medially you will do the motion. Okay. Then you look for the ulnar. You'll palpate for the ulnar nerve and also look for any Tinel sign as well in this one. Okay. So that is one thing. So you look for the ulnar nerve here. Yeah. Then you look for Tinel sign. That is for Tinel sign. Okay. And when we do this, see, when we extend the arm, like when we extend the forearm, this one straight. So usually we will also do the stress test, valgus and varus stress test. Okay. So the elbow range of motion is like 0 to 145 in flexion and extension, and supination is 75 to 85 degrees. In this one, you can see. So this is the 0 degrees. Okay. So this is the 145 degrees. And there is no, you can't, there is no extension actually, like in this one, only like elbow flexion is there. Then after that, extending into the 0 degrees only again. Beyond 0 degrees, you won't find this. In certain individuals, 5 to 10 degrees of laxity will be seen. That's all. So like 0 to 145 degrees is the range of motion. Then after that, supination pronation is around 75 to 85 degrees. Okay. Then special test again, pain, provoke, dysfunction. If there is a dysfunction, you will do functional test. Instability, you will do stress test. And if there is a numbness, you will do some neurological test. Okay. So this is Cosen's test. Cosen's test is for, like we are looking for what? So now you can see in this. So like we are doing what? Wrist extension, and we are resisting that. The examiner is resisting that wrist extension. Extension is done by what? The extensor group of muscles. So if the patient has some lateral epicondylitis or this one, so like tennis elbow, so if the patient will have tenderness over this point. So in this one, you can see extensor muscles are like patient is trying to extend his wrist. So he will have if the patient has pain, then that is lateral epicondylitis or tennis elbow. And similarly, not just wrist, if the patient has extending the fingers, that is the Maudsley's test. That's all. If the wrist, this is for wrist, and this for Maudsley is for all the fingers. So if the patient has pain, again, this is positive. Like we'll consider that as tennis elbow, like lateral epicondylitis. And there is something called Mills test, where we will do some forced flexion. Okay, so forced flexion will also will pull or stretch the extensor tendons. That will also result in pain over this area. Okay, so Mills, Cosen's, and Maudsley's. These three tests are for lateral epicondylitis. So we are just actually doing some stress test, okay, of the muscles. We are stretching the muscles, or we are testing the muscles' capability to resist our this one pressure. Okay. And the other thing is the medial epicondylitis. So this is about the like all we have to again opposite like we have to resist wrist flexion, or else we can do this motion as well. Like you can see on this screen. So you can do this one when you are extending the wrist. If the patient has some pain over the medial aspect, that is also positive. This one, okay. Like this is called as golfer's elbow. Okay, so this is about the like this one, and we will also do some stability tests. This is for ligaments. All these like these tests are for muscles. Here now we'll come to the stability test. These are for ligaments. So valgus stress test, we will extend the elbow and forearm. Then after that, we will apply some valgus stress. So now here we are checking for pain over this area. So ulnar collateral ligaments and this one. So this is for valgus. And similarly, from medial, we'll apply some pressure and we are looking for radial collateral, whereas as R, so radial collateral ligament over the is tested here. Okay. So, and also we have to always in all these three things, neck, shoulder, and this one, vascular examination is important. Always we write. So first skin swelling, deformity, then after that crepitus, then after that neurovascular, no DNVD. So distal neurovascular deficit. These are all must for any ortho examination of joints, musculoskeletal examination. Okay. Then, so to conclude this examination of elbow, so again we are doing what? Inspection, palpation, range of motion assessment, and specific tests. So we inspecting for asymmetry bilaterally, swelling, deformity, scars. Also looking for valgus, varus deformities, and we are observing carrying angle 5 to 15 degrees. So, and also we're palpating for lateral, medial, olecranon, and radial head. Okay, and also we have to check for tenderness and swelling. And range of motion is usually flexion extension is around normal is 0 to 140 degrees and pronation and supination around 75 to 85 degrees. Okay. That is there. Okay. And special tests, tennis elbow, again, we are lateral epicondylitis, medial epicondylitis. Then we are looking for ulnar nerve Tinel's test and also elbow stability, valgus and varus tests. So this is about the elbow examination. To summarize, so always remember three things. Okay, only three. So three here, examination, inspection, palpation, percussion. Again, forget the auscultation. We are using only three senses here. History for hearing. Okay, then eye and inspection and palpation is all required. Okay, history, examination, test, special and neurological examination. We are looking, feeling, and also moving and like moving the joint and muscles, this one, and testing them. Okay, then we have three things to test: bones, joints, bones and joints, and ligaments, muscles. Okay. So, and examination of neck is again same. Inspection, palpation. Then again, range of motion, we will do flexion, extension, all the motions. Then neurological examination, we will test for strength, reflexes, and sensations. When we do neck examination, that itself concludes the upper extremity examination altogether as well. So that's why we are not covering in shoulder and this one. Okay. Then examination of shoulder, again, inspection, palpation, range of motion testing, and specific maneuvers. So inspection, again, we'll look for the same things in all these things, and palpation, and we'll confirm our inspectory findings. And we will do the range of motion active and passive. This will differentiate from some pathology. Okay. And special tests, impingement, rotator cuff, then stability tests, then biceps tendon. And remember this one. So in inspection, palpation, ABCs and sits muscles. That is one thing. And biceps, impingement, and acromioclavicular. So these are the things which you have to remember. So again, elbow, inspection, palpation, range of motion test, assessment, and specific tests. Inspection, again, same thing, symmetry and other things. And we are palpating for tenderness and confirming the inspector findings. Then range of motion test, and flexion extension and pronation supination, and special tests for muscle group and ligaments. Okay. And nerves. And video credits that is for Dr. Mehul, and also my references are this. Okay. And thank you. And I would like to thank Dr. Mehul for giving me this opportunity.